A high impact pro con debate on a topic that's been at the heart of many perioperative management decisions, beta blockers. From reducing cardiac risk to raising concerns over bradycardia and hypotension, beta blockers have long lived in the gray zone of benefit and harm. In this session, we'll hear both sides of the story, pro and con, from two distinguished speakers. To chair this exciting debate, we invite Dr. Ramesh Tikkare, Consultant Fortis Hospital, Mumbai, Dr. Suhas M.K., Associate Professor, GR Medical College, Mangaluru. Our first speaker for the pro side is Dr. Prashant Sajjan, Professor and Chief Consultant Intensivist at EPCMS MSRC. So we welcome Sir to present on the topic Beta Blockers, Perioperative Heroes.
That is not. No, somebody. Very good afternoon to everyone. At the outset, I would like to thank the organizers for giving me this opportunity. So in another probably 15 minutes or so, I'll be talking about the beta blockers, how they are came into our anesthesia field, so when and how it is started. So these are my session objectives. And I'll be discussing the three case scenarios. So the first one is the 56-year-old man. He's a known coronary artery disease, renal failure, hypertension, and he's posted for the AV fistula. So he's already getting the bisoprolol. The second one is a 60-year-old man with no cardiac history, and he's just posted for the inguinal hernia. The third one is the 72-year-old with diabetes and CVA, and she is posted for colostomy. So we'll try to understand which patient needs a beta blocker and which patients need not to start a beta blocker. So to begin with, we all know that the surgery and anesthesia is a very stressful condition. So it triggers a series of neuroendocrine, hormonal, and cardiovascular responses. Out of this one, what we are worried is the development of the myocardial ischemia and arrhythmia. Because we all know that it has been proven that the perioperative MI in a non-cardiac surgeries, it goes up to 1 to 5%, and in a vascular surgery, it goes up to 30%. So our goal of intraoperative management basically depends and relies on reducing the myocardial ischemia, preventing the arrhythmias, and decrease the incidence of major adverse cardiac events in patients, especially those who are at cardiovascular risk. So how our beta blockers help? So we all know that, it is not working, okay. So we all know that beta blockers, they basically act on the beta receptors. It reduces the myocardial contractility, the stroke volume, and the other side, it reduces the heart rate. Basically, the demand will be reduced and the supply will be increased. Basically, by the reducing the heart rate, there will be increase in the coronary perfusion, oxygen. That is how it reduces the MI. This is the basic methodology. So, beta blockers, when anxiety and heartbeat rise like a villains, beta blockers stand as a silent heroes, steadying our bodies and mind. So let us begin, try to understand how the beta blockers developed and how they came into anesthesia practice. So for that, we need to understand the evidences. It dates back to 1996 when the first study was published in which it was atenolol was used to reduce, atenolol was used and it is found to reduce the mortality when it is compared with the placebo for a patient which were undergoing for the non-cardiac surgeries. Again, in 1998, Welles, he used the atenolol, he used prophylactically to reduce the post-operative myocardial ischemia. Again, it was used for the vascular surgeries like aortic and peripheral vascular surgeries, where they used the high doses of the beta blocker to control and reduce the myocardial ischemia. And again, there is one landmark study in 1999, that is Decrease Trial 1. Again, they have used in vascular surgeries, and they showed the similar mortality benefit. So, in a perioperative, where they have used the bisoprolol. So, after this study, what happened is, the beta blockers become all of a sudden, they become very popular. So, they have become an integral part of the clinical use in our anesthesia. And moreover, the same author, the Polderman, he went on in 2006 to show that the major vascular surgery, they need not to undergo any cardiac testing, provided if you can control the heart rate somewhere around 65, the patients will be having the low risk for the MI. So that is when all the doubts started. So everybody started thinking, the investigation started beginning, it has begun. So there is one study which came in 2008. It is a first randomized control trial which was adequately powered to investigate the safety of the perioperative beta blocker. That is the POISE trial. So they also have shown that there is a reduced or a decreased incidence of the non-fatal MI. But at the same time, they have shown that the non-fatal stroke, bradycardia, hypotension, and death were increased. Again, this was followed by the series of the lot of landmark studies have come. So they also show that the stroke, bradycardia, hypotension, and deaths, the incidences were very high. Means what? All of a sudden, which was the beta blocker, which was very much appreciated and was a hero, all of a sudden he has become an anti-hero. So what we can think, whether it is because of the beta blocker itself or the way it has been used or the patient selection, there has to be something, there has to be some mechanism. Let us try to understand what could be the key mechanism for all these problems. So they thought that the hypotension-induced cerebral hypoperfusion, bradycardia, cardiac output, impaired cerebral autoregulation, especially blunting the compensatory mechanism, secondary to the atherosclerosis or a previous stroke. Then there were some contributing factors like attenuation of the beta blocker mediated cerebral vasodilatation and blood loss and dehydration. All these mechanisms were the risk factors for developing the stroke, hypotension, bradycardia, and even the death. So based on that one, there were a lot of studies went on, debate went on. Based on the revised cardiac risk index in 2014, the ACC and the AHA, they have given a guidelines when and how to use the beta blockers. They concluded that if the surgery is the cardiac surgery, the risk is high. If the patient is already on the beta blocker, you need to continue or consider starting the beta blocker. If there is a non-cardiac surgery, low risk or intermediate risk, you have to weigh between benefit versus risk. If there is a vascular surgery, yes, they are the one which are going to benefit. Definitely one should consider to start the beta blocker. So once we know that which surgery beta blockers needs to be started, so then the question comes, how I'm going to start the beta blocker? So timing becomes very, very important. So it should be started at least days or weeks prior to these planned surgeries, and definitely no for starting the hours or day prior to the surgery. Basically, you have to give some time for the body to adjust the new onset of the catecholamine surge. That is the decreased onset of the catecholamine surge. and you have to, dose has to be adjusted in such a way that the heart rate has to be somewhere between 60 to 80, and you should avoid hypotension and a high dose or a long acting drugs. And one has to continue if the patient is already on the beta blocker. And definitely beta blocker should not be considered for obvious reasons: bronchospasm, bradycardia, AV conduction defect, hypotension, etc. So going back to the landmark studies which I was talking about, if you see in this one, those studies in which all of a sudden the beta blockers were the hero, that there they have started the beta blocker just before the induction or a days prior. The one landmark POISE trial, they have started the beta blocker just 2 to 4 hours prior to the surgery. That too, they have used a very high dose of the beta blocker with a sustained release. Probably that is the reason the patient they have some problems or issues. Our beta blocker also helps in the other surgical or anesthesia management, like in case of intraoperative management of the stress response. So whenever there is a airway instrumentation is there, there is a sympathoadrenal discharge will be there. There will be increase in the heart rate, blood pressure, intraocular, intracerebral pressure, everything. These are especially detrimental whenever the patient is having hypertension, coronary artery disease, aneurysm, or anything in the brain. Not only this one, the beta blockers are also helpful in managing the hypertension during the anesthesia. Let it be the laparoscopic surgeries or surgical need of the hypotension, that is a controlled hypotension or a deliberate hypotension. So the beta blockers are the choice of agents. Beta blockers are also known to reduce the anesthetic requirement if you use during intraoperative time. They act by decreasing the physiological stress response. They reduce the excitatory signal, they stabilize the hemodynamics, and also they have the mild sedative effects. So meaning what? Whenever you are planning to use any inhalational anesthetic, for example, if you are planning to give 2% of any of the MAC value of any of the anesthetics, you may require only 1.4 to 1.5 MAC only. That means the requirement comes down by 20 to 30%. Same with the IV anesthetics like propofol. If you are planning to give around 2 to 2.5 mg per kg body weight, so you may require only 1.5 to 2 mg per kg body weight to achieve the same anesthetic levels. Beta blockers are also known to cause the analgesic property. They enhance or potentiate the duration of the action of the opioids, what we are using. See, the mechanism is they inhibit the release of the pro-inflammatory cytokines, they modulate the inhibitory transmitter, they affect the excitation transmitter, and also they alter the pharmacokinetics of the drugs. By reducing the cardiac output, the more drug will be circulating in the body, the duration of the action will be prolonged, and you need a lesser drug to achieve the same analgesic effect. Again, the dose comes down up to 20 to 30%. Meaning what? If you are planning to use, say, around 10 mg of a morphine, you may require only 5 or 6 mg morphine to achieve the same analgesic effect. And these effects are documented to be there for up to 7 days of a post-operative period. Along with that one, the beta blockers are also having the neuroprotective effects. So basically they dampen the sympathetic overactivity, they reduce the inflammation, and they limit the secondary cerebral injury. So because of that one, they reduce the brain trauma severity, they reduce the intraoperative awareness. The awareness basically said to be secondary to the secretion of the noradrenaline, which binds or bonds to have the strong memory, emotional memory. So the beta blockers will take care of that one. So that is how there will be a decreased post-traumatic stress disorder. Not only this one, the beta blockers are the drugs of choice whenever you need to control the heart rate and the blood pressure for various reasons. Let it be the ECT, let it be a thyrotoxicosis or malignant hyperthermia. Wherever the cornerstone of the management of the high pressure or a sympathetic over stimulation, the control of the heart rate and the BP is required, the beta blockers are one of the choices for the same. To summarize, perioperative beta blockers may be appropriate not only just for the cardiac ischemia prevention, but also for the neuroprotection, reducing the anesthetic needs, pain control, hemodynamic stabilization, psychological sequelae mitigation, and one has to remember, however, the care regarding the dose and patient selection remains critical. Going back to the case scenarios which I have stated, so anyone will take in the lead, or shall I continue? I'll continue? Okay. So the first one, so he is a 56-year-old and he is already coronary artery disease and CKD hypertension, AV fistula. So the vascular surgery, there is a very high risk case and the patient is already on the beta blocker. So the idea is to continue throughout the perioperative period. So one should not stop abruptly. In the second one, it is a very low risk and there are no cardiac risk involved in this one, so no need to start the beta blocker. In the third one, the patient is aged, that is 72, and a diabetic and a CVA, and posted for a major surgery. So basically, if you see the revised cardiac index, so this fits into 3+ points. So this is a definitely you have to start, and any major abdominal surgery, this can wait for a couple of weeks. So you can electively start the beta blocker, you can prepare the patient, then you can post the patient for the surgery. That is how you can reduce the mortality. So thank you.
Thank you, sir, for that compelling argument in favor of beta blockers in perioperative